Greetings, everybody. This is Professor Dr. Rodolfo Oviedo, CEO of TRUX, the Robotic Global Surgical Society. It is my honor and pleasure to welcome everyone to today's episode of the Resident Chronicles, Episode 2. One, it's one episode to remember. It's an episode that will be a continuation of the first one that happened several weeks ago. We had a great turnout. We had a great participation from the audience, and we're really looking forward to this episode. And to introduce the director, the course director for this episode, it is my pleasure to say hello to my dear friend, Professor Dr. Luis Suárez Carreón, who's a professor of surgery in Guadalajara, Mexico, and who is also the program director and the chair of the Membership and Engagement Committee for TRUGS. Professor Suarez Carrion, how are you, my dear friend?
Hi, everyone. Fine. Yes, today we have another episode and we are emotionated. And I have the pleasure to share this session with a great team, a team from Guadalajara, and direct and share with you, my friend. It's a pleasure. I hope we have and enjoy this panel and this session. Thank you so much.
Thank you. And before we introduce our distinguished panel to talk about the episode for the Resident Chronicles today, with 3 surgical problems, 1 robotic team, we will talk about the second surgical problem. But the first one, we'll briefly discuss what we did several weeks ago when we had the first episode. Now we're going to talk about problem number 2. And this will be given as a grand rounds presentation by our distinguished resident physicians from Guadalajara, Mexico. But before we do that, I'd like to take a minute to acknowledge our industry partner at TRUGS, and I am referring to Lipoline. Lipoline is a company based in France. It's a global company, although the headquarters are in France. It is our industry partner, thanks to which we are able to conduct educational activities such as these, brought to you by Robotic Theater Productions on Surgeon. Lipoline is a company that makes the finest type of materials dedicated to manufacturing binders for patients who undergo metabolic and bariatric surgery or plastic and reconstructive surgery or abdominal wall reconstruction surgery, including cancer cases. So this is ideal for patients who suffer from overweight and obesity. And why is this important? Because compression has been proven to be an effective method to decrease edema, to decrease seroma formation, which sometimes leads to complications, and we'll be discussing that today. In addition, it helps with pain control and adopting an ergonomic posture, a more appropriate posture for patients. It increases activity. So all of these issues also contribute to controlling pain. And so we encourage everyone to check out Lipoline. Go to our website at trogs.org, meaning trogss.org. Not only consider becoming a member of TRUGS for free so that you can be a member of the One Global family. And that not only includes doctors and medical students, but it also includes healthcare professionals such as nurses, nurse practitioners, OR technologists, etc. So we invite everyone to check out our website. And if you go down to the section, our industry partners, you will learn about Lipoline. It'll take you to their website and everything they have to offer for your patients. So having said that, we will now begin the introductions and we'll present each of the distinguished speakers that I have the pleasure of having met with them several times already, and it's a delight for me to be here with them. Professor Suárez Carreón, can you please introduce our speakers?
Yeah, please. Today we have the company of 3 grades residents of different degrees, and we have with Dr. Holanda, Dr. Rodrigo, and Gonzalo, and Chema. And I would like you introduce myself, please, my team. Thank you so much for sharing this session. Rodrigo, sorry, first Holanda, first ladies, please.
Hello, everybody. I'm a surgical resident. I'm a 3rd-year resident. It's a pleasure to be here with you, and I hope we all enjoy and learn more of these surgical problems and how to solve them each one. Thank you.
Rodrigo.
Hi, good morning. Thankful for being here again with the second episode of these surgical problems, and hope all our audience enjoy it.
Thank you so much, Rodrigo. Gonzalo, how are you?
Hi, hi. Thank you for the invitation.
Thank you so much. And Chema?
Well, I'm pretty glad being here with this great opportunity. It's a pleasure in this second episode. So I am pretty sure we're gonna learn a lot in this session. So thanks for the opportunity.
Okay, thank you so much. We are ready.
Before we continue, I'd like to say something. It's I almost said it and I ruined the surprise, but we are definitely trying to recruit Professor Suárez Carreón to become a program director for our intercontinental training program. Not only is he the chair for the membership and engagement committee, he's a distinguished leader at Trucks, but we're really hoping that his center will become another intercontinental training program center. So that would become center number 9. We're really, really hoping that will become a reality. We're working on it, and we'll keep working on it. So thank you very much for considering it, Professor.
Such a great honor. We don't believe it, but we are emotionated with this project. Thank you so much for the consideration. We enjoy.
Okay, well, after the introductions, we're ready to go. So we're going to dedicate the next 40 minutes or so, for approximately 45 minutes to discussion, ground rounds, video review, etc. And then the last 10 minutes will be for Q&A. And of course, anybody can type their questions and we'll be addressing them one at a time. Let's get started.
Okay, well, let's start the Resident Chronicles, episode 2. So, three surgical problems, one robotic team. Okay. On the prev episode, we talk about the magnificence of the robotic surgery, the way we can use the robotic surgery as some problem solves for our patients. We talk about a patient that has 3 surgical problems. First, also we talk about the sleeve gastrectomy as a rehabilitation abdominal wall. We have that our patient weight was 111 with a body mass index of 40. We achieved 67 kilograms for her and a body mass index of 24. We talk about one of the most relevant, that is obesity, one of her problems. We talk about also tips and tricks of how we do a sleeve gastrectomy by a robotic platform. We also talk about the cartridge and also to be careful with the spleen. Also, we talk about one other surgical problems with this patient, that is the huge hernia defect that in this radiologist report told that is 10 by 10 centimeters, but we saw a different uh, size of this hernia defect on the real life. Okay, this is the tomography, and here is the robotic view. When we made the sleeve gastrectomy, we saw that is a huge hernia defect, and also is uh, um, a way to we rehabilitate our abdominal wall. Yes. Okay. Here was the board placement of the prep surgical uh, procedure about the sleeve gastrectomy, and we saw the hernia defect is before we start about talking about that.
That is a huge defect, Dr. Hernandez. So do you remember the measurement?
It's like 15 centimeters.
Greater than 15
greater than
centimeters.
15.
Exactly. So I know that you guys are going to talk about at some point prehabilitation. You'll be talking about Botox injections. We'll be talking about the timing. When do we fix a hernia like this? Do we do it concomitantly with metabolic and bariatric surgery? Do we do the bariatric surgery before? Do we do this before bariatric surgery? So we'll be talking about that at the ground rounds portion of the talk. And at the same time, this was a very large hernia, more than 15 centimeters. But not only that, you have to take into account that one thing is a hernia defect. Something else, I don't know if you can appreciate that on the video, is how much abdominal wall does the patient have to reconstruct the posterior rectus sheath. You see, because a hernia defect, we can close it by doing a component separation. We can do an anterior release or posterior release. In this case, robotically, we can do a transverse abdominis release. Okay, but that sounds great. But how much posterior sheath will you have available when you have partial loss of domain? You may not have enough posterior sheath to reconstruct it. And so in that case, a sublay would not make much sense, right? Unless you put a patch to reconstruct the posterior sheath. Alternatively, you could do other things that we'll discuss on the video, or you can do what was done in this case, which was a hybrid approach, meaning you do what we call a focused or modified TAR, in which you just go for the transverse abdominis. You don't create a full rectal rectus flap. And then from a mini laparotomy, small incision the size of one hand, after you have released the abdominal wall, now it's easier to put together the fascia. And then you can do an onlay, and you put your prosthesis or your mesh or your implant on top of the fascial closure. So why don't we talk about that? But let's continue the video, and then I think you have more to say about adhesiolysis and other things. Please go ahead.
Yeah, let's continue with the revision of the articles.
Yeah, so just as Dr. Villa said, well, there's a problem when we talk about bariatric surgery and hernia repair because, well, evidence says that 8% of bariatric surgery patients have a concomitant ventral hernia. So it's an important decision to know when to perform the hernia repair. So we have to ask ourselves, should we perform a simultaneous repair, bariatric surgery first, or hernia repair first? And evidence is very clear in this way. So can you put the next one, please, Rodrigo? Yeah, here we have level 1 evidence. Here we have a systematic review and a meta-analysis, and it's pretty clear about the advantage of performing bariatric surgery first. So in this way, here we can see that we can achieve a great rehabilitation of abdominal wall, and we have to follow our patients for at least 12 months, but conclusion is very clear. It's very clear in that way. Here we can improve overall complications, surgical site infection, and hospital length of stay. Can you please put the next one? And here we have another original article from Surgery for Obesity and Related Diseases journal that shows just what I said. Please put the next one. Here we can see two groups of patients. The first group, there was performed the hernia repair, and the second group, it was performed the bariatric surgery first. And we can see in the next one, please. Just what I said. It's remarked in hospital stay days. Here we can see the p-value that is statistically significant in that way. And we can see as well the reduction in surgical site infection and overall complications. So the way that we resolved this problem with this surgical team, with this robotic surgical team, it was the correct way. So in conclusion, bariatric surgery first.
That's interesting to say. And Dr. Suarez, Professor Suárez Carreón, I'm interested in hearing your perspective too. You see, this topic has always been discussed at meetings such as IPSO, ASMBS. I remember I was at the IPSO meeting in Naples, IPSO Napoli 2023. That's when you and I met in person. Yeah, I remember that. And we discussed it too, because you see, there's a lot of controversy sometimes, but I think with Dr. Zepeda's systematic review that he showed, this has been already established, right? The best timing to do this is, of course, we do the metabolic bariatric procedure first. Ideally, if the patient can wait, right? If the hernia is not so incarcerated or doesn't lead to strangulation, we can wait it out. We can do the weight loss metabolic procedure first. Then the patient is optimized to eventually have abdominal wall reconstruction. Because you see, the other way is if we do the hernia first, it has a much higher likelihood of recurring. And it happens to all of us. And then doing it at the same time, a hernia like this, absolutely not recommended. Not a good idea. The patient is not going to recover well from either one. It's too much to handle. What do you think, Professor?
Yes. Always is the debate about the stage approach versus the concomitant approach, and all depends, and we need to profile each case. It's that the size of the defect and also the BMI are relevant for take decisions. So one concept that I understand now in the discussion and evidence is small defects we can wait, right? If you have the plaque in the patch of momentum, and this is important, check there is that plaque initially and after you conclude your surgery and you're going to retire and prove you have that plaque. But we are talking about the small defects. But what about the higher defects or big defects? Defects like this, more than 10 centimeters, in this case, more than 15. I think the stage approach and in my practice, I prefer for the stage approach. First, bariatric surgery, solve the BMI, and then conclude with the second episode like this for a final repair with best prognostic results, you know. So I think this is my opinion in this. This is the data, but always my point of view is we need to profile each patient. And the take of decision during the surgery, like this case we're going to discuss today, is quite important, and understand why we take these decisions, because each patient is unique.
And take a look at this paper from one of the most esteemed, revered, and admired professors of surgery and metabolic and bariatric surgeons in the world. This is from Professor Ramon Vilallonga Puy from Barcelona. So please, let's go ahead and talk about this from Professor Vilallonga, and let's discuss it.
Yeah, just what we said, and just what we have been talking since the first episode. Bariatric surgery is the rehabilitation of the patient. So that's what we can conclude about this.
I love that. I love that. Metabolic and bariatric surgery is prehab. It is prehab. So let's discuss more about prehabilitation. What does it include? Is it only medications? Is it lifestyle modifications? Is it nutrition? Is it mindfulness? Is it pharmaceutical options? What is it? Or is it a combination of all of them?
Rehabilitation of abdominal wall has emerged in recent years a multidisciplinary strategy to optimize patients before the surgery, as you say, with the objective of reducing postoperative morbidity and enhancing recovery. This approach includes nutritional support, physical activity programs, and psychological preparation. For example, in the article Preparative Optimization for Abdominal Wall Reconstruction recommends levels of A1C lower of 8% and stop smoking at least 2 weeks. Can you plug the next part? Obesity focused rehabilitation states for ventral hernia. In this study, evaluate the impact of different preparative weight loss strategies. Here, bariatric surgery emerged as the most effective method for achieving significant weight body mass index reduction. The next.
Now, this is interesting. Botulinum toxin. So let's talk about that and why, and the issues that sometimes we have to deal with as surgeons when we want to implement an important strategy, but sometimes we're not able to do it because of administrative reasons. But Botox or botulinum toxin is also important for prehabilitation of the abdominal wall. Not in all cases, but in certain select cases, like this one. Let's talk about it.
In complex scenarios such as loss of domain hernias, additional preparative measures are required to facilitate fascial closure. According to the article Preparative Botulinum Toxin and Progressive Pneumoperitoneum in loss of domain hernias, the decision is aided by the hernia to abdominal cavity volume ratio. If the ratio is less than 20% and the defect is less than 12 centimeters, no additional therapy is needed. If the ratio is less than 20%, but the defect is larger than 12 centimeters, botulinum toxin is recommended 30 days before surgery. If the ratio is greater than 20%, botulinum toxin should be administered 30 days before surgery and in combination with progressive pneumoperitoneum initiation 10 days before the pressure.
Very interesting. So, Dr. Delgado, repeat one more time. Let us know about the formula. What is the formula to make this calculation to get the quotient, the coefficient?
You need the ratio of the index, the hernia to abdominal cavity volume. So if the volume is less than 20%, depends the larger of the measure. If less than 12 centimeters, you don't need a other therapy. If is excess of 12 centimeters, you are recommended to use botulinum toxin.
Okay. And in this case, it was greater than 15 centimeters. And this patient would have been a candidate for Botox injection. But unfortunately, due to administrative reasons and permits and authorizations that we had to request, we were not able to offer her Botox. I think if the patient had undergone progressive serial Botox injections in anticipation for surgery, perhaps we could have achieved greater compliance and laxity of the abdominal wall to the point that we may have achieved complete closure of the posterior sheath with a total robotic approach, right? But in this case, it was not possible. Therefore, we had to make an intraoperative decision. Once we get in, we see the size of the defect. We already knew that. But once we see that she does not have enough compliance, enough laxity to have enough posterior sheath to be closed, then that doesn't make sense, right? We have to innovate and improvise within surgical parameters, of course, within safety. And we had to perform what we call a modified or focus star. And we'll be talking about that on the video. And then we do a hybrid approach. And you see, there's nothing wrong. One more thing, and I want to hear from Professor Suárez Carreón's opinion. There's nothing wrong with doing something as a hybrid approach for safety reasons. If it's the right thing to do for your patient, we need to forget about our pride. We need to let go of our pride as surgeons, and we need to let go of that sense of what are people going to say about me. They're going to say that I converted. They're going to say that I'm not a great robotic surgeon. No, we are surgeons above all, and we have to apply judgment. And if it means making a small incision the size of one hand as a mini laparotomy to be able to do an onlay repair after you have done a focus star, so be it. It's the right thing to do, and the patients do really well, as opposed to not doing anything or making a very long incision and committing to open from the beginning, or leaving the posterior sheath. What happens when we leave the posterior sheath open? It's very important, and Professor Suárez Carreón can tell you the same. We've seen hernias like this. We didn't talk about these hernias before because we were not doing so many TARs or component separations minimally invasively, etc. It's called intramural. An intramural hernia is from the Latin that means between walls. It's a hernia that happens through a partial portion of the abdominal wall, not the whole thing. It's, for example, when you have a gap in the posterior sheath, or you do a TAR and it opens up, but the hernia defect is already well closed. That's no issue, right? The fascia is closed because you did a beautiful TAR, yet the posterior sheath, the posterior rectus sheath, is not as strong. And so when you closed it partially, or you didn't do a great job, or you have too much tension, it ruptures. What happens? A piece of bowel or a hollow viscous will get into the preperitoneal space, right? Into the retrorectus space, and it gets trapped, and that becomes incarcerated, and it's as bad and sometimes even worse than the real transmural hernia. So this is called intramural hernia. And we do not want to have that. That would be a disaster for the patient, right? But let's continue. Dr.
Yeah.
Suarez, what do you think about this?
Yeah, of course. Is not just to close the defect. Is the same principle in hernia in general. Is not to close with tension, and we need to, and that principle respect for avoid this complication. So it's not just close. Is close without tension. Is that why we need to do many times more than just close? And we are talking about that.
Well, with the pore placement, this is a diagram that how this surgery is made with 6 trocars and the huge hernia effect just in the middle. This is how it was performed in this patient, and also the position of the patient and the ergonomy that the robotic surgery give us.
So you see the typical side lateral placement of the trocars, right? We begin on the left abdominal wall. You can use your mouse to show it. Left upper quadrant. We go in with optical entry in the left upper quadrant. And then we put the other 2 trocars on the left side of the abdominal wall. We examine the situation. We see the size of the defect. Under normal circumstances, Dr. Hernandez, you can show the video later from the YouTube channel where we can show a video when we do a totally robotic TAR. The classical scenario is when you leave the hernia sac and the hernia defect, you treat it as an island, so to speak, like an island. Leave it, dissect around, create your retrorectus flap on the right side. You're gonna make your flap from the left to the right. Then you protect the semilunar line. You do not violate the semilunar line, so you don't create an iatrogenic Spigelian hernia. Then you find the transversus abdominis muscle just underneath the rib cage on the right side, the right upper quadrant. You find the fibers, you divide the fibers, you protect the transversalis fascia. We'll show that on the video. And then once you've done your release, then you flip the boom of the robot, depending on what robot you're using. If you're using the Da Vinci, if you're using a competition type of robot, like different robotic platforms, like the modular ones, the ones that don't have a boom, that they have independent arms, and we can talk about robotic platforms later, then even better, you don't have to worry about flipping any boom. Then you're just ready to go for the other side. You put mirror image trocars, you put them on the other side, and then you repeat. Same thing you did for the right abdominal wall, now you're going to do for the left abdominal wall. You do your flap, your retrorectus flap, you do your transversus abdominis. Now you have enough laxity, like Professor Suárez Carreón was saying, that you can now close the posterior sheath without tension. That's the key. However, what happens if you cannot close without tension? What happens if you can't approximate the posterior sheath? Then you can always extend the transversus abdominis to beyond the confines where you normally go while protecting the semilunar line. Remember that the transversus abdominis muscle comes medial in the upper abdomen, but it goes lateral. You will have to chase it laterally. Remember what happens below the level of the arcuate line? The contributions to the posterior sheath are weak. So you could end up having another hernia. So be careful there. So what we do sometimes is we put a patch to close that defect on the posterior sheath. We do a patch. You can use whatever implant you prefer, as long as it has an anti-adhesive layer to protect the bowel from adhesions. Or the other thing to do could be to close transversely, horizontally and transversely, or diagonally as much as you can. But if there is too much tension, you have to do what we did here, which is what we're going to discuss in the video. You abandon any type of idea of doing a complete flap, retrorectus. Just go for what we call the focused TAR. Just go for the transversus abdominis. You still make a retrorectus flap, but it's not the whole way. Go for the transversus abdominis, do your job, put drains, close the flap, and now the peritoneum, at least, of course, not the muscle, just the peritoneum. And then you do the mini laparotomy, one hand, go in, and now you can close the fascia completely, and then you do an onlay. And the patient does really, really well. So let's talk about that on the video.
All right.
So now we are going to watch the video and make it easier to understand what just Dr. Ovidio just tried to explain. Just to remember that the TAR is a component separation technique designed to facilitate the closure of large abdominal hernia walls And now we are watching the video. It's a view from above, how it's supposed to be the incision and the pore placement in the right and the left side of the abdomen. Now we are in, and we are going to start to begin the adherencylysis, and then okay, so can you please fast forward? Thank you. So now the adherencylysis is just start, and just to remember that you need to be careful, and if you want any injury, you need to repair it, because you don't want anything else to complicate your post-operate. We are releasing.
A lot of dense adhesions there, huh, Dr. Garcia? A lot of dense adhesions. And like you said, the important thing is if you make an injury or serosal tear, you recognize it, visualize it, and fix it right there, right? Because if you miss it, you're gonna have a problem post-op day 2 or 3. You could have a leak, perforation.
Yes. If you fast forward the video, we can see how you just warn the injury and you repair it.
Mm-hmm. That's a serosal tear. That's an example of what we're talking about. Exactly. This
Yes.
happens when we do adhesiolysis. You at some point you may have a little tear. You just have to recognize it. What do you think, Dr. Garcia, about the use of energy versus no energy when you use adhesiolysis? Some people do use energy. What do you think about that?
Well, you need to be you need to have the experience to use the energy and be pretty juicioso. I just
But
forgot.
yeah, be very you have to show good judgment, right? You have to
Right.
be wise, because the problem is if you use a lot of energy when you do adhesiolysis, you could have coagulation necrosis by post-op day 2 or 3. You can have a perforation or fistula in evolution, right? If you make a clean cut with scissors, you can fix that, right? We do anastomosis all the time by hand. It's not a problem. And of course, we don't want to sound arrogant either, right? Anything could happen, but we're very careful usually. But the main thing is try to avoid using energy when you do adhesiolysis if you can avoid it.
Yes.
What are we doing there?
Now we are just going to start to create, well,
so these ports are being placed as lateral.
Excuse me?
Yeah, the ports are being placed as lateral as possible. This is a huge defect, right? And this
Yes.
patient didn't really have a big she was a little short. This patient was, of course, she suffered from obesity, but she was a little short. Not a lot of room to do anything there. So keep going, please.
Yes, the adherencylysis it keeps going, just to create the space and to visualize right the places we are going to put the pore placement. If you fast forward,
Yeah, we can fast forward to a place where we can visualize the hernia defect and appreciate it. Maybe towards the middle. Okay, we begin to see that. It's quite a large defect. It was about 17 centimeters, if I remember correctly. Though, so some people would have committed to doing that open from the beginning. I get it, and nothing wrong with that. It's just that you're committing to a lot of potential problems and infection and fascial dehiscence. And now, in this case, we wanted to give the patient a chance to have a robotic approach, and we did it as a hybrid, meaning robotic, focused TAR, adhesiolysis. Then we do the onlay, and it's much easier to do the onlay repair with a mini laparotomy incision.
yes, and that's what you just said. We are going to watch it on the video. And once you reduce all the hernial content, you start to look where you are going to place the ports. The port placement begins after the hernia is reduced. Now we fast forward.
Okay, so this is what we decided to just focus on the tar, right? So we're making a flap, but it's a modified flap. It's not an entire retrorectus flap. It's only the upper portion of the retrorectus space. We're making a flap with a curvilinear incision. And then what is the purpose here, Dr. Garcia?
So here we are going to open the peritoneum and to get to the abdominal rectus. And then
we're also, not only the peritoneum, Dr. Garcia, but we're also reflecting the posterior rectus sheath. You see, we're in the retrorectus space there. Yeah, go ahead.
Yes. And then we are going to create the flap just to watch the abdominal, the transversus abdominal rectus. And then we are going to identify the semilunar line. So,
which is the lateral border of the rectus abdominis muscle. And we're going to protect the semilunar line. We're not going to destroy it so that we don't create a Spigelian hernia. What are we doing there? That's the key here. What muscle is that we're splitting?
The transversal.
Exactly. That's the transverse abdominis. You can find it under the rib cage, right? So you find it there in the upper abdomen. It's very medial. As you know, sometimes the atlases are wrong when they don't show you how medial that muscle can go. It can go really medial, and that's to our advantage. We find it, and then you see it almost looks like the Peruvian or Canadian or Austrian flap, red, white, red. And so what is it? Red is, of course, the fibers of the transversus abdominis. White is the transversalis fascia in the middle, and red is the fibers again. So you want to look at it as a flag from Austria, from Peru, or from Canada, right? And that's the best way to remember. Do not destroy the posterior sheath, right? I'm sorry, the transversalis fascia, because if you do, you're going to have a defect down into the peritoneal cavity. And you see how far do you chase it? How far do you go with the transverse abdominis? That was one question Professor Suárez Carreón had. What do you think, my dear friend? How far do you go when you do your TAR?
Yes, my friend. I try to never cross the semilunaris line as possible it is, and go to the higher level in the edge of the costal margins. Can be my proportion of my length of the TAR, right? So one question is, you can do a partial TAR or you need to complete. All depends. You need to. I try to affront, and some friends and in hernia. If a moderate TAR is enough for close without tension, that's the first point.
Yeah.
Close without tension. Do partial, but semilunar line, costal margin. I think in that margins you can do or perform a good TAR, I think.
Good. And Dr. Garcia, why are we putting a drain there? Some people don't leave drains at all. Why a drain?
Because we are doing it to create the once we create the space of the rectum flap, we need to place the drain, because we are closing it after we place it, because we are going to try after the closure of it, we are going to do it the hybrid repair.
But some surgeons would not leave a drain. I believe it's important to do that because that you will have a seroma no matter what. You'll have like you said, it's a potential space. It's gonna fill up with fluid, and so you will have a seroma, and that may lead to discomfort and possible complications, infection, etc. So it's always better to drain that. And anyway, for the most part, that drain stays there for about a week or two, and that's it. You remove it in the office, so it's no major issue. Patients appreciate that, and they understand they're gonna have a drain. And now when you do that, you close it just like you would close the flap when you do an inguinal hernia repair, like a tap. You see how it looks? It almost looks like a tap. Now, I think what we're doing here is we're measuring to make sure that we understand the dimensions of this massive hernia, and definitely greater than 17 centimeters. So we decide at this point it's not going to work out. If we try, because of the dimensions of the abdominal wall in this patient, the fact she did not get Botox, we just don't have enough posterior sheath to close. It's not enough. So we're just going to have to do it as a hybrid. So we do the TAR on the other side. We're about to flip the boom because we're using the XI Da Vinci model. If we were using another platform like Dexter, Medtronic, or Versius, or the other robotic, or Mantra, or the other ones that don't have a boom, or some of the Chinese robots, then, or Japanese robot, or so some of those, or the Korean ones, then we would not have to deal with the boom, and so we would just change the position of the arms, modify the position of the arms, and then you put your trocars on the other side, and then you're ready to do your flap, right? And that's what you're about to do. You're going to do your flap on the other side.
Yes, we just created the right rectus flap, and then we are going to do the left rectus flap.
So I think what's happening here is we're trying to put ports without destroying what we just did, right? So we have to put ports around the flap that we created so we can flip that boom, right? You can fast forward just a little bit. So we're just going to have to put ports, mirror image ports. That's it. But let's go to the other side. Now we're going to flip the boom. And with this transition, now we're going to start doing the mini flap or the focus flap on the left abdominal wall.
Right.
Yeah. We're moving well with time. We're moving along. It's 40 minutes, 41 minutes since we started. So this is exciting. So we have more time for Q&A and discussions, but we don't have to hurry up. We're doing really well. And then we can even show that edited video from the YouTube channel from Surgical Excellence Academy, where we have the edited video showing the complete TAR, like the classic robotic TAR, just to compare to what we did here.
We are creating the left rectus flap, just above the port placement.
Yes.
It's the same as the contralateral side. There we see the muscle.
The rectus abdominis, and then you see the semilunar line, and you do not violate that, right?
Right. It's
there is a muscle. There's a transverse abdominis.
There it is. You are releasing it.
Let's remember that we always have to visualize the transversalis fascia. The edge of the costal margin, of course, is a superior edge, and then the inferior limit is when you go. The more inferior the muscle, the more lateral it becomes, and it tracks laterally. Remember that if you try to do a release below the arcuate line, it's not going to work out very well because the contributions are weak. So it goes really lateral at that point,
Doctor,
depending on the patient's anatomy.
I have a question.
Yeah.
The port placement this way does not contribute for an incisional iatrogenic hernia?
Yeah, good question. No, we close those defects, those little defects in the port. We don't show on the video here, but we close the little defects with Vicryl, for example. And no, because the repair that you're going to do as an onlay, Dr. Hernandez, is going to cover that anyway. Your onlay will include those little defects. But good question. Yeah, we close those little defects in the peritoneum. Now, these are 8-millimeter ports. I know what you're thinking. Sometimes even 8-millimeter ports can lead to port side hernias. Good, but we close them. So now we do the release, right? We do that release. It looks like the Canadian or Peruvian or Austrian flag. Now, when you're happy with that, you keep checking you didn't destroy the transversalis fascia. You protected the semilunar line. You did not create an iatrogenic Spigelian hernia. Once you do that, you finish your release. There it is. And then we place the drain, and then we close that flap. And now we're ready to transition to the mini laparotomy portion of the procedure, when we're going to, obviously, we're going to close that fascia completely. And then we can talk about the use of barbed sutures, non-barbed sutures, all of that. We're going to close the fascia completely, close the hernia, and then we do the only repair with whatever implant the surgeon chooses, right? Depending on whether you want to use synthetic or resolvable synthetic or reinforced biologic or truly biologic. It's a surgeon's choice, right? This is not a case to be discussing what choice of mesh to use or implant. Is more the technique. Keep going, please, Dr. Garcia. You're doing great.
Thank you. So we close the flap we just created as the other side.
That's what
Once the closure of the fascia is done, excuse me, what?
That's what Rodri asked, correct? The Dr. Oviedo is closing the port placement.
Yes. And this is it. Now, what are we doing in this? We're about to transition to the helicopter or drone view, right? We're about to do the mini laparotomy.
So now a view from above. We have the incision in the abdomen. Now we are going to place the mesh, an onlay mesh. And as the doctor said, you can choose whatever mesh you have or you want. So we are making sure we have the right space to place it.
Now, if you can pause the video there, doctor, so you have to make sure that when you do this, you have to really create your subcutaneous flaps to be able to expose, of course, because you have to close all that massive defect. Yes, the incision looks small, but you have to develop your subcutaneous flaps. And yes, I know what you're thinking. Well, now you're developing the potential for big seroma formation and complications. I get it, which is why we drain that too. Not only do we put drains in the mini flaps that we just created, we also put drains above the prosthesis, above the onlay repair. Absolutely. If you don't do that, you're going to have more problems. You're going to have a patient with seroma formation, possible complications, infection. Now, I'm happy with the fascial closure because I just did a TAR, bilateral TAR. The TAR was complete. It's not that we did a less of a TAR. We did a TAR. It was a beautiful TAR. We did it bilaterally. It's just that we didn't create the retrorectus flaps completely, right? Now we closed the fascial defect completely in the middle. And then this is the importance of using products such as the ones that we discussed. Now we're in the educational portion of the talk, so no, I'm not going to name any products, but binders, for example, abdominal binders are very important. Not for the prehab, but for the rehab, the rehabilitation after surgery. So let's talk about what is being done here, Dr. Garcia. Please describe.
So now we just placed the onlay mesh. We are making sure we have covered the defect. And if you fast forward, I think we are going to watch how we place the drain. And then if you see, you can watch the drains placed before when we create the rectus flap, and then we close the incision of the abdomen.
I
Very
think
nice.
That's a beautiful video, and we can see that concept of a sandwich of drains, right? The drains you placed in the in the flaps, and in our onlay placement of the mesh. It's pretty nice to see.
If you pause it, you can. I don't know how to point, but if you help me, please, Rodrigo.
Yeah.
I want to comment something. I look. This is what we are talking about. Profile the case, and we achieve the objective of solve the hernia. A beautiful demonstration with the use of the robot. I just thought when I don't have robot, this is I would like to perform by laparoscopy. I don't know how technical difficulties can I have, but I see that it's possible. But one advantage that I see in the hybrid technique now is, yeah, we are worried for the seroma, but also we have the advantage for solve the complete decision of the sac. That is other fact for seroma. So is something that in minimal invasive surgery in the IPON we need after with Dr. Cucleta that says IPON plus is better with decision of the sac and avoid the seroma. With big defects, more big sacs and more chances of seroma. So hybrid technique, I like this technique because we can solve the sac and we can expect less chances of pseudo hernia also, because we close the defect, but we have sac and we have the content, momentum, etc. And we take a TAC tomography by control, and sometimes something see like hernia, but it's not a hernia. It's just sac with content, but we don't take it out. So I think this don't give chances for permit and sac and pseudo hernia in these terms.
Thank you for that wonderful comment, my friend. I do have a couple of comments, but before we do that, for the next 9 minutes, I would like to show the little video from Surgical Excellence Academy's website, from the YouTube channel, so we can show how a totally robotic TAR is done, right? Just to compare, no hybrid, it's completely robotic, no open incisions, nothing like that. So if you can, doctors, if you can go to the Surgical Excellence Academy channel, you already have the video ready. And yes, can it be done laparoscopic? Absolutely, it can be, especially the hybrid technique, but also a totally lap TAR. It can be done. It's just a little more challenging, but it can be done. The other thing is the concept of the sac. You're right. Now, how do we circumvent that issue when we do a TAR and we're not going to remove the sac? We treat it like an island, right? So we actually incorporate bites of the sac on the fascial closure to close that potential space. It's almost like when plastic surgeons do an umbilicoplasty, right? When you incorporate the sac and the abdominal wall and the skin, we put them together to minimize that potential space. Well, that's the same concept. We incorporate with the bites, incorporate the sac, and close that space. So we don't leave a huge space between the sac and the fascial closure. But we can, and that's another thing to consider as well. But we can play that video. And in the meantime, while we play the video, go ahead. I'm going to check for questions from the audience. And here we can narrate it. Professor Suárez Carreón, if you want to narrate a little bit what's being done while I look for questions from the audience. This is a complete TAR.
Yeah.
You can see the video?
Yes, we can see it.
It's because I can put the whole.
Yeah, we can see it. And we can see how
we can see how we're creating that. You see how we're isolating that island of sac with hernia, massive defect. This wasn't as big as the other patient that we just took care of, but you can see how we're creating the right retrorectus space, and we're protecting the semilunar line, and now we're about to do the transversus abdominis release on the right side. We're looking for that Canadian or Austrian or Peruvian flag concept where we see red, white, and red, which is muscle, transversalis fascia, and muscle. We're about to, there you go, red, white, red, right? You can use your imagination there. We're going from the subcostal margin all the way to where the muscle becomes too lateral to chase, right? Now we're putting mirror image ports. We're using the XI, so we're going to flip the boom. Now you have the other view. You're looking at the right abdominal wall. You're about to create the right retrorectus flap. We just flipped the boom, right? 180. Now we're creating the right retrorectus flap. We'll repeat the same thing you did, right? Same thing. So now you look for the costal margin. You're going to find that transversus abdominis because it's a very medial muscle in the superior abdomen. Now the ports, you need to back him up a little bit, right? Those ports, you're going to back him up and put him in the retrorectus space. And then we continue where we're going to find that muscle and we're going to do the transversus abdominis release, which is about to happen right now. There you go. So we do the transversus abdominis release where you protect the semilunar line so we're not creating an iatrogenic hernia. Yeah. And now when we finish that, we're about to close that posterior sheath, which is very lax and very relaxed, and right, because we just did the transverse abdominis. So now it's easy to close the posterior rectus sheath. So I call it the floor. We have the concept of the ceiling or the roof versus the floor. We're about to close the floor. When we close that floor, so to speak, the posterior sheath, then you become truly extraperitoneal, right? Now, this is what we could not do on the first case because the patient did not have enough laxity, did not have compliance enough to do this. It would have been impossible. So that's what we went ahead and did the improvisation to do a hybrid approach, which is nothing wrong with that. We already established we need to let our ego disappear and vanish, and the pride, and really do the right thing for the patient. Here, it's easier to close that posterior sheath. And now what are we doing? We're closing the roof or the ceiling, right? Now we're looking up, we're closing the anterior aspect of the hernia. And after that is just placing the process. Oh, here we're incorporating the sac. You see, we're incorporating bites of the sac with every bite so that we can decrease that potential space. And now at the end, we're about to place that prosthesis. Then it's surgeon's choice. You can use a mesh that is lightweight, light molecular weight, macroporous mesh. You can use a resorbable synthetic. You can use a biologic tissue matrix, whatever you prefer according to your hospital administrator's budget and what you think is the right thing to do for your patient. This is not the purpose of this talk. We're not talking about any product or endorsing anything, right? It's just a technique. Wonderful. So 4 minutes to finish. And if you have any questions for the discussion, I'm looking for questions in the chat. Gentlemen, let me know if you, and lady and gentlemen, let me know if you see anything. I do not see any questions in the chat, but please go ahead.
I think that you just answered a lot of these questions, along this discussion. But I want to ask, what's the difference between performing a TAR in the standard patient versus performing it in the obese patient? So I know that it's obvious that, as Dr. Robert Bruce said, decisions are more important than incisions. But what's the difference, or what are the difficulties that you face when you perform a TAR in the obese patient, particularly?
Great question. I'll let Professor Suárez Carreón answer that question. He has a lot of experience with fixing hernias in both patients with obesity or patients without obesity.
Yes, as we know, the incidence is less than 10%, but more or less 8% of all obese patients must to have weakened to have a hernia. So we need to take decisions, right? So actually, the most common defect that I have experienced is the umbilical, right? So if the umbilical is in a small defect in obese patients, so I need to see if have a plaque or don't have. So if have plaque and I perform a sleeve or I can finish a bypass, in general, we don't need to move that plaque of omentum in the umbilicum. So we can finish and we can pass for a second stage repair for this patient. So is that the common scenario that most I see in the bariatric patients? But not only umbilical, there are also ventral hernias. We, in our third level of reference hospital, we have ventral hernias with lost domain, and we need to do a protocol that just perform an sleeve, then achieve the BMI, then rehabilitation with Botox, and then prepare for a TAR. So in general, for lost domain, we prepare for open TAR. Is that the more frequent cases that we prepare in the lost domain? But all depends. I come back for the profile each case, and also always respect the concepts of the hernia in the data, and you don't fail. You don't have more chances to fail. Yeah, we can have bad days. But if you respect the concepts of the repairs hernia and rehabilitation, you have more chances of success.
And now we know that we have a hybrid technique, so you don't have to necessarily commit to doing an open TAR on a patient with obesity. We try not to say obese patients according to ASMBS guidelines, so that we can remove the stigma and that adjective from the patient. So we now say patient with obesity, just like we say patient with diabetes or patient with cancer as a disease. And so we try the best we can to avoid the complications from doing an open approach. Nothing wrong with doing it, but if we could do it minimally invasively, even better, right? So we can now begin to do it with lab or robotic techniques. And if we see that we cannot complete the job robotically or lab, we can do the hybrid approach, just as we described today. If that is not enough, absolutely, you can open. Nobody is going to fault you for that. You are still a surgeon. You're still doing the right thing for your patient. I think that's the main concept here, right? When we do the Resident Chronicles, we try to instill that concept that judgment comes first. The attention to detail and the safety for the patient is first, regardless of the approach that you choose. The center should be the patient. That should be the center of what you do. Yeah. Any last minute comments to say goodbye and thank you to our audience and prepare for the next webinar in a few weeks?
Yes,
Sure.
I think it was pretty interesting seeing the approach that Dr. Oviedo performed in this patient. It's complex, and I think that just as Professor said, each patient is a world. So thanks for this opportunity.
Thank you. And so I see that we have an episode 3. So what's going to happen in episode 3?
We'll be approaching the third problem that our patient has.
It sounds like it's a surprise, huh? So let's leave it as a surprise.
Stay tuned.
Okay. Stay tuned and please join us for episode 3 of the Resident Chronicles series. I also take advantage of this to tell everyone, please become a member of Drugs. We really invite you to be a member of this global society and one global family. We really want you in our society. It's free membership. What do you have to lose? You have so much to gain. And once you join us, you're going to find a world of networking and mentorship, research, educational opportunities. You will have the opportunity to lead a global webinar such as this if you have the spirit, the energy, the dedication to do it. So I invite everyone to join. How do you do it? You join for free at trogss.org or trucks.org. Check it out, the Robotic Global Surgical Society. Check out our LinkedIn page. We're very active. We are all over the place in social media. Become a member. It's very easy to do. You follow the registration link, then you get a letter from Professor Suárez Carreón and the co-chairs of the Membership and Engagement Committee. The WhatsApp group is private. It's just for the members, just to communicate and encourage each other. But that's not what we are. We're not a WhatsApp group. We're not just a WhatsApp community, all due respect to those who do that. We're not a Facebook community. No, we are a global surgical society, officially registered in France. We have a constitution in French. Our official language is French, but our common language is English to communicate with everyone. We are here for you, and we promote surgical education for all. Check out the page, and please join us. Thank you, Professor Suárez Carreón. Thank you, doctors, all of you. I'm extremely proud of you. And I can tell you, when I was at your level, I was not leading global webinars like you are. So you're far ahead of the curve compared to where I was. So thank you.
Thank you,
Thank you
Doctor.
so much. See you in the same.
There are some questions at the chat.
Yes, go ahead.
They came in. Any time frame if I do this laparoscopically? I mean, how long should it take? And how should I pick patients eligible for this technique? And how did I fix that only mesh when you did the combined robotic open approach?
Let's see. Let's talk about the first question. So thank you for your question, dear member who is watching. Any time frame if I do this laparoscopically? Yes, of course, it's going to take a little longer if you do it laparoscopically because you don't have the ergonomic advantages, articulation with the robot. But I don't think so much about the time. I want you to focus not so much on the time. If I could give you a short answer, something like this, the robotic part, if you have a lot of experience, may take you less than 2 hours. I mean, it all depends on the adhesive lysis. If you do it lab, you may be adding 1 hour, maybe 30 minutes. It all depends. Don't focus so much on the time, all due respect. Focus on the finesse and the technique and the elegance and the respect for the tissues. You'll see that the more you do it, the faster you'll become, not because you're speeding up. It's just because you're being more efficient with your team. And don't do this maybe once a quarter, once every 3 months. Do it as often as you can, right? Because with volume, with experience, you and the team will get better. And how long should it take? I think I answered that. How should I pick patients eligible for this technique? We talked about it. It's really consider the patient's abdominal wall defect, consider the laxity, consider whether you can inject Botox or not, consider prehab, and then we established that anything greater than 10, 12 centimeters is a good candidate for TAR, but it all depends on the size of the patient. Anything beyond 15, be careful. You may have to do a hybrid approach. 17 centimeters, definitely hybrid. I think it's very difficult to do a TAR, completely robotic TAR. Not impossible, but difficult. And then the other question is, how did I fix that only mesh when you did the combined robotic open? I'm sorry, I don't think I understand that question very well, but when you did the combined robotic open approach, how did I fix it? We fixed it with the onlay, right? So we close the hernia defect. That's the concept. We close the hernia defect completely. We don't leave a gap. And then on top of it, we put the implant or mesh or whatever implant you use on top. We chose to do an onlay. Could I have chosen to do an underlay? Sure, I could have. But I believe that onlay is a good solution here, and you avoid complications from adhesions, etc. Right? So I didn't want my implant touching the viscera. Thank you for the question. What's the next question? That's it, right?
I
Yes,
think that's it.
that's it.
Okay. Well, thank you so much, everyone. Professor Suárez Carreón, can you close the session for our audience, please?
Yeah, thank you so much for joining us today. Please, this is coming a surprise. Is possible a third problem in the same patient? Wow. Let's see what is going to happen now. Okay, and please join us for trucks. There is a big family for the residents. There are many projects, very interesting, very fresh. Like a family. This is, I love it. What is we're doing. Please join us, and let's see the next episode, please. Just thank you so much for everybody. See you soon. Dr. Professor Oviedo, thank you so much always for this lecture. I learned so much, and I think everybody, thank you so much. See you soon.
See you soon. Thank you,
Bye.
everybody.